Hello, everybody. Hi. I've selected some cases to discuss for today's class. Now, let's have a look at the first one. A 49-year-old man with a history of alcohol abuse. How is this related to the image of his liver, the alcohol abuse? What do we see that is consistent with the toxic action of alcohol in the image? It's very typical. Yes, this is some sort of an adipose metamorphosis of liver cells. That means that liver cells themselves are transformed into adipose cells. They are not just adipose cells being abandoned from an obese patient that come to the liver. No, the liver cells themselves are transformed into lipocytes, and this steatosis is reversible. It's not the only cause, it's the main cause as far as Western countries are concerned, but it's not the only cause. For example, hepatitis C also has some degree of steatosis. And other factors, children that are undernourished in protein, their liver cells react in this way. But the most common cause is alcohol abuse. Yes, but...
What is the mechanism that allows the hepatocytes to be transformed? I'm the right person to ask me the biochemical mechanisms that lipids concentrate? No, you're wrong. I'm not the right person. You look it up yourself and let me know. Yeah. Oh, of course, some sort of metabolism in the cytoplasm of the liver cell. It's a very good question, but I'm afraid I'm not the right person to answer these questions, because as I said, we try here to understand basic clinical knowledge. So you look it up, you let me know, okay? I always want to learn, despite my age. So, and he has an increasing abdominal girth. So, connected to liver disease. How do we explain this increase in the abdominal diameter? What has happened there? And we have the patient with an increased abdominal girth related to a disease of the liver. Yes? Ascites. It's ascites, yes. And we either think of a mechanical obstruction through portal vein circulation. This is cirrhosis, but it's not necessary for the liver to become cirrhotic so that ascites is formed. What else can happen? Having to do with the osmotic pressure of the blood. What can happen if the liver does not function well? Remember what we said in our first lesson? Yes? Yes, there is a low protein in the blood, so the osmotic pressure is low, and plasma goes out of the vessel. And we have ascites. So, liver dysfunction can cause ascites in two ways. Either low albumin concentration in the serum, because this is the synthetic function of liver, the albumin levels show that. Or we have a mechanical obstruction due to cirrhosis, and the portal tract circulation cannot pass through the cirrhotic liver to go to the hepatic veins and then enter the inferior vena cava, so we have portal hypertension. Now, and let's have a test. I'm sure you know it because you are much too close to high school than me. You have the weight of the patient is 60 kilograms, and 50% of this weight is water. And we are looking for the blood ethanol level. It's quite similar to what we look in the alco tests, all right, to see. If he has consumed a bottle of wine, 750 milliliters with a 14% ethanol and a specific gravity of 0.79. It's simple. Simple, but as I have forgotten all this knowledge for high school, I had to go back and see what does the special gravity means. It's milligrams to volume. So since I found out, I'll tell you what I found out and you'll tell me if I'm right, okay? So 14% of 750 milliliters is 105 milliliters. If we multiply this to the specific gravity, we turn it into milligrams. So how much alcohol is there in the patient? In milligrams, 83. Is it clear till here? Is it not? You understand this? Am I correct in my calculations? No. No. Yes, correct me then.
In the parentheses it says milligrams per deciliter and then you have milligrams per milliliter.
No, it's milliliter. It's 700. Next. Cool down, Webb. Not come to the other. Slowly. Don't be so anxious. We'll go there. Did we find the milligrams of ethanol in the patient? We found it. So, now, 83 milligrams. Now, this is distributed to 30 liters. Is this 300 deciliters? The 30 liters? Is this transformation correct? Yes. 1 deciliter, how many milliliters are there in 1 deciliter? How many milliliters are there in 1? 100, that's right. So, look here. If we divide the milligrams with the total, here, the volume, we find 277 milligrams per deciliter. Is that okay? That is equal to 0.25 grams in deciliter. Is that clear? So this is quite high, and it can cause a severe mental impairment. So what do we see here? All these adipocytes are related to alcohol abuse, and what part of the liver parenchyma is this here? What part is it? What do you think? Is it, you know, the architecture, the tissue architecture? We have the central vein and the portal tract. What does this write on the bottom to the left is? What is this? Is it a central vein or a portal tract? Hi? What do you think? In the portal tract, we have to be able to recognize, to identify the structures of the portal heart. Which are the structures? The part of the portal vein, the part of the hepatic artery, the arteriole, and the bile duct. If you find one or two of them, it's enough. So if you see the image here, this could be epithelium. So this is probably a bile duct. Ductule, not duct, ductule. So this is probably a portal tract. Here now, another alcoholic patient who develops jaundice. That means he becomes yellow. The scleros here, you see it under the daylight, and it appears yellow. So, which finding of the biochemical examination is consistent with this clinical image of jaundice? Which one? Have a look at the values in the biochemical profile of the patient's serum. Which one is consistent? Yes? Yes. So when we have high bilirubin levels, this is quite high, then from one point and on, the patient becomes yellow. Now, if we have bilirubinemia, we must see if it's direct or indirect. Here, it is mainly direct. As I told you in the first lesson, when we have a problem in bile
bile circulation to the bowel and it is after the liver, then direct bilirubin is high. When the problem is within the liver cells themselves, then we have mainly direct, but also sometimes indirect bilirubin, because there is not enough conjunction of the bilirubin to become conjugated. So in diseases affecting the liver itself, we can have both types of bilirubinemia. And when the problem is before the liver, that means it's due to hemolysis of red blood cells, then we have indirect bilirubinemia. Okay, is that clear? So have a look now at the other couple of enzymes. One is aminotransferase, which are quite high. What does increased aminotransferase levels mean? What does this mean? Damage to liver cells themselves. So when we have high aminotransferase levels, this is consistent with some sort of hepatitis, that liver cells are destroyed by many factors. Mainly, if we have a virus, they are destroyed by the immune system, who tries to eliminate the virusly infected liver cells. Other causes of hepatitis may be autoimmune causes, alcoholic hepatitis as part of a metabolic syndrome it may cause, and how do all sorts of hepatitis are recognizable? Increase of aminotransferase. And when this increase is too high and we have values more than 1,000, then this is an acute hepatitis which can destroy more than 85 to 90% of the liver, and these are the very rare cases of fatal acute hepatitis. In no way is this the rule. This is a very rare exception. The rule is that there is damage. If it is virus, the virus is most commonly eliminated. A small percentage transforms to chronic hepatitis, which affects the aminotransferase levels for about 6 weeks and more. And a much less proportion of these patients develop cirrhosis. As far as hepatocyte carcinoma risk is concerned, of course, it has a relation to cirrhosis, but it can develop in HBV-infected patients which have not yet developed cirrhosis. So it's not mandatory that liver cell cancer is on the background of cirrhosis. But most commonly, it is. So, what else here? Those were the aminotransferases levels which show us that there is active inflammation, active hepatitis. What else do we have here to... here is the alkaline phosphatase, the hepatic isoenzyme. Is this high? Is its value high? Yes, it is. However, it is not so high as the aminotransferase. So the fact that the hepatic isoenzyme of alkaline phosphatase is increased shows us that there is some sort of obstruction in the circulation of the bile. However, the main damage is of hepatitis, because comparatively the levels of aminotransferases are much more increased than the level of alkaline phosphatase. So when we see the couple of liver enzymes, one is the aminotransferases and the other is alkaline phosphatase and gamma GT. Of course, we take into account if their values are increased, but we also see how much they are increased for each couple. Next, we have an INR of 2, which is quite long. What is this related to? The increased INR. That shows us something about the blood. Yes?
It has to do with the amount of albumin that there is in the blood.
Oh, no, it has to do, the INR is something to measure how the blood coagulates, because all coagulative factors, and specifically those dependent on vitamin K, are synthesized by liver cells. So if liver cells do not function well, we have a prolonged partial thromboplastin time. That means the blood cannot coagulate soon enough. And we have hemorrhagic signs. That's why some liver patients have all those, like some hemangiomas, areas of hemorrhage on their skin, because the coagulative factors are not properly produced by the damaged liver cells. Next. And the white blood cell, there is some sort of increased white blood cells. So this is what you see, and what we see from an histological point of view, what can this pigment be here, which is related to the increased alkaline phosphatase and the patient's jaundice? What is this? This is cholesterol, yes? Yes, this is cholestasis, intrahepatic. And these here, you see these structures here within this liver cell are known as Mallory bodies, which are consistent with alcoholic etiology, but they are not pathognomonic. That means when you see these Mallory bodies here, these cytoplasmic structures, it's not necessarily of alcoholic etiopathogenesis. However, it is most common is. So, and always remember that the increased aminotransferase represent hepatocyte necrosis. So we have a biliary obstruction within the liver parenchyma, and the result is direct hyperbilirubinemia. Yes, please.
What is the red thing that you asked?
The what?
The red thing, this.
Is it red? Red? No, not red. Cholestasis, yes, intrahepatic cholestasis, stasis. What's in the gallbladder? What's this? Bile? Bile, yes. It's bile, how do we call it? We call it in Greek, it's a bile plug. It plugs. That means it occludes the sinusoid. The sinusoid, because how is bile produced? It's produced by liver cells. It's produced by liver cells and circulates through the canaliculi and reaches the bile ductule in the portal triad. Then the bile ductules become bigger and bigger, and they leave the liver and go to the common bile duct to the duodenum. Faters.
Why do you have the obstruction?
Why do we have the obstruction? Because this is it. This is, what are you looking at? The offers, the Black Friday offers you're looking now. Oh, yeah. Yes. Pay attention here, pay attention. Because if you see that what other cells are there in this field which are consistent with inflammation? What other cells? Have a look here. Can you identify these cells? Look, what cells are they? Have a look at their nuclei. They are neutrophils. Why are they there? Because liver cells have been destroyed. So we have hepatitis. This is why the aminotransferases are so high. What is the cause of hepatitis? No virus, no autoimmune mechanism, it's alcohol. So since we have inflammation and we have all these cells within the liver trabeculae, the bile cannot find its way because there is some sort of architectural distortion within the liver lobule.
So we have stasis.
So is it because we have a lot of cells there?
There is
or-
inflammation,
or the
inflammation, and if this is from one time point and next, then we'll have fibrous tissue developing, and this may lead to alcoholic cirrhosis. So there is some sort of damage in the circulation of the bile through the canaliculi to the portal tract, bile ducts. So this is cholestasis, right? Pay attention if you have a SUS offer, I'm interested.
Yeah,
Yes,
okay.
pay attention, yes. So, yes?
We say again why the INR is recessed because you have less fibrin or...
No, the INI is due to a diminished production of coagulative factors. That means factors that make the blood make a clot.
Yes, thank you.
So, next case. This is cirrhosis. You see? A diffuse abnormality throughout the liver, which is replaced instead of lobules by cirrhotic nodules. And what is the consequence? What is the consequence? Ascites. This is mechanical ascites. Mechanical ascites, not just due to low albumin synthesis. This is mechanical ascites. And, of course, the low albumin levels contribute to the development of ascites, but here we have a mechanical obstacle. So, have a look at the aminotransferase levels. They are quite high, and the patient dies from uncontrollable hematemesis. How is this justified? Why does such a patient have an uncontrollable hematemesis? Hematemesis means that you see blood, red blood, in the vomit. So how can this be explained? This is mechanical obstruction leading to portal hypertension. So the blood tries to find ways not to pass through the liver. And one of such ways is that of the left gastric vein, which goes to the lower esophagus veins of the submucosa, and they go up to the azygos, thank God, azygos vein, and then it goes to superior vena cava. And so the liver is not, it does not pass through the liver. However, if we have an alcoholic patient, this is a most dangerous complication because those lower esophagus dilated veins, when veins are dilated, how are they called? Varices, yes. They break and we have a fatal hemorrhage. This is a complication of portal hypertension, mainly in alcoholic cirrhosis patients. All right. This is cirrhosis, you see? The nodules, the cirrhotic nodules, here they are. And there is some degree of steatosis. Have a look at the aminotransferase levels. They are quite high. So the inflammation is active. And we have, he was an intravenous drug abuser, so hematogenously, he was infected by a virus of hepatitis. However, when we see a worsening in clinical symptoms of cirrhosis, either the function of the liver, which can affect also the brain, because if the NH3 products are not detoxified, the brain is affected. So in such cases, that it becomes worse in a patient with a known cirrhosis, we suspect two things. Either a cancer has developed on the background of cirrhosis, or there was a reinfection. An additional virus came to infect the liver cells. And in this case, the additional virus was that of hepatitis delta. And please pay attention here to the percentages showing us the evolution
of the viral infection of the liver. Only a small risk, there is only a small portion develops cirrhosis. However, in these patients, there is a considerable risk of hepatocyte carcinoma development, hepatocellular carcinoma. Now, what is all this area here? Look, all this part of the liver has been affected, and what can these subcutaneous structures be that they are so dilated? What can this be? This is something that is consistent with states of hypercoagulation. That means when a woman takes oral contraceptives, when we have adiphospholipid syndrome and there are clots formed in the blood, when we have nocturnal paroxysmal hematuria, that's another, a site of hypercoagulation in the blood. And most commonly than all these factors, pregnancy, the period postpartum, the most common factor that predisposes the blood to form clots is cancer. Because cancer patients' blood, there are frequent clots formed in the blood, and so many cancer patients die of what? If there are clots formed in the blood, what does the clot go? If it leaves the place it was formed, it goes and comes pulmonary, mainly pulmonary embolisms. So what happened here? There was some sort of clot formation, but it was not in, it was in the hepatic veins that take the blood from the central veins of the hepatic lobules, and then they go to inferior vena cava. So this is called Budd-Chiari syndrome. And its etiology is that of the hypercoagulative disorders I have mentioned previously. Yes?
Why does cancer increase thrombosis? Is it because of paraneoplastic syndrome?
Yes, it's probably something like that. It's called like the Trousseau phlebitis, mainly in pancreatic cancer patients. We'll see a case. Next. Yes, it's some sort of paraneoplastic syndrome. Yes. Now, so I see that the hemoglobin level is rather high. How can this be justified? What do you think? This is another factor that predisposes to Budd-Chiari syndrome. It's polycythemia. That means increased percentage of cells circulating in the blood. Want to ask something? Yes, please. Yes.
How do we distinguish between a hepatitis from an infection and a hepatitis from alcoholism?
Yes. First, the patient's history. If he is a drug abuser, if he has multiple sexual partners, mainly hematogeneously, hepatitis C virus is transmitted. Hepatitis B virus is transmitted sexually, mainly. And hepatitis A virus, it's through the mouth or it's through the oral anal route. Okay? If the toilet is not clean enough, you may be infected from hepatitis A virus. Yes?
From the results that we get from the lab, can we distinguish between the two?
You have to correlate it with the patient's history, how much alcohol he consumes, and if you suspect a virus, you ask for the markers of virus. That means the antigens and the antibodies, so that you can see if the antibodies are IgM, it's a recent viral infection. If they are IgG, it's an older one. But most viral hepatitis are subclinical. You do not know that it's hepatitis. If it causes icterus and it causes some obstruction in the bile circulation, then you find it. You can detect it clinically. And you measure the aminotransferase levels, and you see. Next. Here is cholestasis. You see? All these plugs, And what is the history? Ah, it has a colicky right upper quadrant abdominal pain. Now, if you have a patient with cholestasis, oh, wake up, you lose the offers, come, you lose the Black Friday offers. It's no time to sleep now. No, you have to be alert so that you get all offers and go and buy. It's a tough day, yes. Why is it difficult today? Black Friday.
No, next week. Next week is Black Friday.
Yes, it started from October. It's okay. Not only next week. So, what do we see here? Have a look. I want you to tell me that there is direct hyperbilirubinemia. You can see that. And an increase in alkaline phosphatase. So, you see that there is evident cholestasis with bile plugs in the liver's parenchyma. However, it also has a colicky pain. What's a colicky pain? It's a pain that you cannot sit in one place. In order to be comfortable, you move all the time. It makes you somehow better, feeling better. So when you have a colic anywhere in the body, this is related to muscle spasm. You have, for example, a kidney colic. A stone has moved through the ureter and causes spasm. Similarly, here in the liver, there is a bile stone which left the gallbladder, went to the cystic duct, went down to the common bile duct and occluded. That is why it hurts. So you must pay attention. If the pain is colicky, there is a stone. So you have to make an ERCP, find the stone, and try to move it away. This obstruction that causes considerable pain affects the liver parenchyma, and if it is not treated in time, then it can become cirrhotic, because bile stays in the liver, and this is the colic cirrhosis, another type of cirrhosis, which develops when bile remains within the liver parenchyma. So, this stone that goes there and occludes the common bile duct can also be involved in the pancreatic fluid circulation through the main duct of the pancreas to the duodenum. In this case, if the occlusion prevents the circulation of pancreatic fluid, the pancreatic fluid will stay within the pancreas, it cannot leave, so it will be excreted from the ducts, and it will cause damage to the pancreatic parenchyma and to the fat tissue surrounding. And this will cause another pain that will affect the peritoneum, because this will be acute pancreatitis. The most common cause of acute pancreatitis is obstruction of the bile duct by bile stones. Of course, there are other etiologies as well. In such case, which enzymes will also be increased in the patient's serum? The enzymes that cannot go to the duodenum and reach the blood circulation. Yes? Tell me? That's a general marker of inflammation. Of course, if you have inflammation, it may be increased. But what are the enzymes in the exocrine pancreas? That amylase, lipase, yes, all these will be increased in the serum. And they will be highly increased in cases of acute pancreatitis. We'll see a case. However, this is not a case of pancreatitis. It's just an colic due to obstruction. And of course, in all cases of obstruction, either if it's a tumor within the liver that occludes somehow the circulation of bile, or it is a stone, we have an increase in alkaline phosphatase. But always take care that you check the hepatic isoenzyme, because the same enzyme increases in other types of disease, such as the one we studied in the previous semester, and it affects the bones, and we measure the levels of alkaline phosphatase to make them correlate with the stage of the disease. You remember which bone disease has to do with the alkaline phosphatase increase in the serum, but not the hepatic hyoenzyme, the osteoblastic hyoenzyme. Which disease is that? No, that would have markers of inflammation. It's a metabolic disease, Paget disease of the bone. Okay? Anyway, you can come next semester that I'll probably be doing all the lessons of the pathology 1, and we'll study them again. Come here next semester, you'll come here. You are welcome. You are welcome. As I can see, I'll do them all. Do all the lessons. Yes. Okay. Next. Oh, what's the abnormal finding here? What is all this fluid? I want you to discriminate where is the ascitic fluid and where is the air. Because here we have two problems, and the much more dangerous is the air, which gathers there in the abdomen. So, let's have a look now. Increasing abdominal girth. I want to see if this is normal or abnormal. However, you can see that all this, what is this? Fluid, all right? This is ascites. What's the case here? You see the collection of marked peritoneal fluid, and all this has affected the brain because the liver cell can no longer detoxicate, and secondarily, the kidney is also affected, and this is called the hepatorenal syndrome. That's why we have an increase in blood urea nitrogen and creatinine levels. And we also, the amount of urine is diminished. So, if we have this cirrhosis, there is a possibility that renal function is affected. Now, we have another type of cirrhosis here, which is not yet in this stage, that we see. What cells are these? With their small round nuclei and not enough cytoplasm. What cells are those that are so dense in the portal tracts and they attack these bile ducts and destroy them? However, the bile ducts are destroyed in the terminal disease. What cells are they? Can you identify them? What cells are they? Because these are the cause of they are related to the cause of the disease. What cells are they? Small cells with round nuclei, not a significant amount of cytoplasm, yes? Lymphocytes, this is an immune inflammation that destroys bile ducts, and this is primary colic cholangitis, which may develop to cirrhosis. And of course, it causes cholestasis, because if they are destroyed, the bile cannot circulate, and we have hecterus, and most interestingly, we have increased amounts of cholesterol. A very good marker to find in the serum of patients with primary colic cholangitis is some sort of autoantibodies, because this is an autoimmune disease, which I'm sure that they have been stressed in the previous lessons, which are these autoantibodies, which are quite consistent with the diagnosis of primary colic cholangitis. You remember them? What are they called? Yes? Antimitochondrial. Let's have a look. Their title is very helpful. So, it doesn't show it here, so I can tell you myself. It's antimitochondrial antibodies. Haven't you heard of them? Antimitochondrial antibodies. Consistent with primary
primary colic cholangitis. This is biliary, primary not colic, sorry, primary biliary cholangitis. All right? Yes, you find them? Portal tracts.
Yes, but that's what it caused the primary biliary cholangitis.
Yes, yes, that's the causal factor. It's autoimmune inflammation, as is the next case, which can develop to cirrhosis, but in contrary to the previous case, this case affects bigger bile ducts, and this is primary sclerosing cholangitis, most often related to ulcerative colitis. And you see this onion-like sclerosis through around bile ducts. Primary sclerosing cholangitis. Of course, the bile ducts are sclerosed, so bile cannot circulate and leave the liver and the common bile duct because they are stenosed. The large-sized and medium-sized bile ducts are stenosed by the fibrous tissue around them, and you can see that also in the X-rays. So what will be increased in the patient's serum? What will be increased in the patient's serum? Yes? Alkaline phosphatase, yes, and bilirubin. So this is an hepatocellular adenoma. Sorry, no time. Anything you want, you can write it in the video. Okay? And I'll answer. This is a hepatocellular adenoma, a benign tumor, which, however, we must take and follow the patient so that it does not break, because if it breaks, hemoperitoneum will develop, and this will be a very dangerous case. This is hepatocellular carcinoma, and there is a marker related to its development, especially in cirrhotic patients, and this tumor marker, which is found in the blood, is alpha fetoprotein. So if you have a cirrhotic patient and you measure the levels of alpha fetoprotein and you find them to be increased, you think that on a dysplastic cirrhotic nodule, a hepatocellular carcinoma has developed. And this is another primary tumor of the liver. What differentiation do you see here? What is this differentiation? What structures are these that this malignant tumor forms? Glands. This is a primary cholangiocarcinoma. Cholangiocarcinoma. Okay? This is not related to cirrhosis, like hepatocellular carcinoma. And you see that it has caused an obstruction that does not permit bile to enter the gut. So we have increasing jaundice, pale stools, because bile is what stains the stools brown. So if there is not bile enough in the duodenum, then the stools are pale. And what else cannot be absorbed? What else cannot be absorbed? Fat. So you have steatoria. And the same happens when there is not enough pancreatic fluid in the gut, such as happens when the parenchyma of pancreas becomes atrophic. In chronic pancreatitis, you can have steatoria, as well as in other diseases, such as Crohn's disease, that affects the gut itself. This is pancreatic adenocarcinoma, and I want you to pay attention that the patient has jaundice, because if this develops in the head of the pancreas, then we have obstruction of the common bile duct, and bile cannot move to the gut. But this pain is it's not like the colic that we saw with the stone that made the obstruction. This is a very low pain. Perhaps if some peripheral nerves are invaded by the cancer, it can cause pain, but under no circumstances is this the intense colicky pain of the stone obstruction. All right? So, if you have a patient with increasing jaundice without pain,
or without significant pain, without acute pain, then you have to look what happens in the head of his pancreas. If the tumor is in the tail of the pancreas or in the body of the pancreas, there will not be jaundice. There isn't a reason for jaundice to develop, so the diagnosis may be delayed. And here is the paraneoplastic tumor syndrome we have already mentioned, where clots are formed by the cancerous cells. And there is here are the stones in the bile, which can cause the colic pain and obstruction. Here is acute pancreatitis with fat tissue necrosis due to the pancreatic fluid enzymes which come out of the pancreas because they cannot leave the pancreas another way through the pancreatic duct and be excreted in the gut. And what we have here, this is another cause of steatoria. This is chronic, all right? This is chronic pancreatitis, which makes the pancreatic parenchyma become atrophic. So those were our cases.